The next speaker is Dr. Vikesh Singh, another colleague of mine I've known for over a decade. He's been kind enough to serve on the executive committee for CAPER. He is has been the medical director for the Pancreatitis Center at Johns Hopkins. He's an associate professor there. He's also the medical director of the Total Pancreatectomy Auto-Islet Transplantation Program there, as well as the director of endoscopy. So we can just call him the director. But anyways, it's my honor and privilege to invite Vikesh to talk about chronic pancreatitis, a topic he's very familiar with and well published on.
Good morning, and I'd like to thank the CAPER Organizing Committee for this opportunity to speak with you today. So I'm going to be talking to you about giving you an overview of chronic pancreatitis, which of course also is a quite cumbersome topic, but I'll try to hit on what I think are key points for people who are practitioners in this space today. I will not provide the overview of what will be taking place a little later today in Washington, D.C. But turning our gears to chronic pancreatitis, just a couple of sort of important points. One is, of course, we know that chronic inflammation of the pancreas can lead to fibrosis of the gland. We also know that recurrent episodes of acute pancreatitis can lead to chronic pancreatitis. And it's important to remember that there are, of course, many symptoms that can be present in patients with chronic pancreatitis. The most common is the presence of intermittent or chronic upper abdominal pain. And that is really found in about 80 to 90% of patients at some point during their history. Over time, patients are also at risk of developing both exocrine insufficiency and diabetes. Exocrine insufficiency is characterized by either steatorrhea or loose, oily stools, weight loss and or malnutrition. And of course, endocrine insufficiency is characterized by diabetes. And of course, there'll be a talk about that by Dr. Bellin a little later on today. Now, there are also some complications that can come along the course of chronic pancreatitis. I would say these are largely structural complications, including pseudocysts, the obstruction of the duodenum, which can occur when you have an enlarged head of the pancreas. These patients can also develop biliary strictures, fistulas to not only the skin, but also the surrounding organs around the pancreas, as well as there's a risk of pancreatic cancer. So really, what is chronic pancreatitis? I think this is very important to sort of step back and ask ourselves, really, what is it? We know what some of the symptoms are, we know what some of the complications are, but I think it's important to remember that at the end of the day, chronic pancreatitis is a syndrome. And it's a syndrome characterized by the presence of symptoms, some of which we've already mentioned, morphologic changes of the pancreas, which can include anything from calcifications, changes of the duct, atrophy of the gland, the presence of pseudocysts, as well as fibrosis, if you were able to get a tissue biopsy or a surgical resection specimen and could look at it under a microscope. And finally, functional changes, which we have discussed, the exocrine insufficiency and diabetes. Well, one of the biggest problems is that there's really no universal agreement amongst pancreatic specialists as to how many individual categories and findings are required for a diagnosis of chronic pancreatitis. We do know that the natural history of chronic pancreatitis can be variable by patient, and it can also be variable over time. So if you look at, if this is a hypothetical patient with chronic pancreatitis, you can see in the blue sort of mountains there are episodes of acute pancreatitis, and sort of the red line is a gradual development of complications of the disease, including diabetes, as well as steatorrhea. And as you can see, the less prominent sort of blue hills are episodes of pain. So you can have a combination of pain and acute pancreatitis that are occurring over variable rates over time, as well as the development of the complications of chronic pancreatitis. So this can be different in each and every patient, and I think that's what makes everything difficult with regards to diagnosing these patients. We also know that the natural history of complications can differ between what the etiology of your chronic pancreatitis is. So this was a nice study conducted almost 25 years ago by Peter Layer and published in Gastroenterology. And as you can see, of course, this probably didn't magnify quite as well on the slide, but the probability of developing exocrine insufficiency, which is the far left panel, calcifications, which is the middle panel, and on the far right, you have the development of diabetes. You can see that the patients with alcoholic chronic pancreatitis, who have the darkest line there, were at the risk of more rapid development of all three of these complications and morphologic features compared to patients who've had idiopathic chronic pancreatitis. We also know that the rates of complications in chronic pancreatitis can differ between different gene mutation classes. And this was a study conducted almost 16 years ago, coming from a German group, looking at patients who carry the SPINK1 gene mutation compared to those who have a PRSS1 gene mutation. And as you can see, there are differences in morphologic progression of disease between patients with SPINK1 mutations and PRSS1 mutations, as well as the development of diabetes. This study showed that actually patients with SPINK1 gene mutations were at risk of a more rapidly progressive course compared to those with PRSS1 gene mutations. So what's also interesting about chronic pancreatitis is at the end of the day, the disease is typically defined by its most advanced end-stage morphologic findings. So if you look at the left-hand panel here, that's was nicely sort of shown by Dr. Gorlick as just being a normal pancreas with sort of with its different cellular elements and its association with the surrounding organs. And if you look over on the right-hand side here, you can see you've got a very irregular gland that's atrophic, that's got a dilated duct and the presence of calcifications and stones within the ductal system. And over time, of course, there's a development of this of fibrosis due to the chronic inflammation. So really these end stage changes are how we typically diagnose this condition. Where we have problems is really the middle of this disease. So we just discussed the end stage findings of chronic pancreatitis. And if we were to think about this as a mechanistic pathway, it's important to recognize that there are going to be patients who are at risk of chronic pancreatitis. Those patients can go on to develop either acute or recurrent acute pancreatitis. But where we have the most difficulty is figuring out who has early chronic pancreatitis, or maybe even established if you look at this mechanistic sequence. So we're really good at defining the disease by its end stage characterizations. And we know those who may be at risk, and certainly those who have acute and acute recurrent pancreatitis also form a more rich population of patients who will go on to develop end-stage disease. But where we have the biggest problems are really the middle of this mechanistic pathway. So I think another important point, if we now start by talking a little bit about risk, and that is that really single-factor etiologies of chronic pancreatitis are likely too simplistic. So, you know, a lot of us were shown this sort of pie graph back in medical school as to what percentage of patients with chronic pancreatitis had what etiology, you know, really based on single factor concepts. So about 65–70% of patients have an alcoholic etiology. Another 10% had sort of a myriad of things, including everything from cystic fibrosis to hereditary hypertriglyceridemia and autoimmune. And that left probably another 20–30% of patients with idiopathic chronic pancreatitis. But what we've known is over time, we've discovered many gene mutations, and we've also further defined the role of smoking in chronic pancreatitis. So while idiopathic chronic pancreatitis was commonly slated as a prevalence, population-based prevalence of about 15–30%, the truth is this number has probably gradually come down as we've elucidated more genetic variants that are involved in the development of chronic pancreatitis, as well as the role of smoking. But I do think it's important to remember that the single factor etiology concept, or the single risk factor concept for chronic pancreatitis, I think is going a little bit by the wayside, because the truth is we probably need 2 or more risk factors to develop chronic pancreatitis. And there's many things that sort of support this notion. One is amongst heavy alcohol drinkers, the lifetime risk of pancreatitis is only 4% among men and 0.7% among women. What about patients with high triglyceride levels? If you define that as being a cutoff of greater than 1,000 milligrams per deciliter, the lifetime risk of pancreatitis is only 10 or 20%. That means the other 80% of people who are walking around with a triglyceride level of 1,000 or greater than 1,000 will never develop pancreatitis. Let's think of another patient population. What about those patients with cystic fibrosis? So we know that about 85–87% of patients are born with CF. Right? They have no Asner cells. They can't get pancreatitis, and they're also born pancreas insufficient. But about 13% of CF patients are actually born pancreas sufficient, meaning they're still making digestive enzymes because they have Asner cell volume. But why is it that only 20% of these patients get pancreatitis and the other 80% do not? So this sort of begs a question that there must be another factor that drives the risk of developing pancreatitis and, of course, eventually chronic pancreatitis in these patients. And really, I think that this is sort of one of the key slides of this talk, is that the risk and progression of pancreatitis is a complex interplay of both environmental and genetic factors. It's very unlikely that just one risk factor is driving disease. So if you look on the left-hand side here, you have a host of environmental factors that we've come to know very well. These are really, many of these are really what we call the single factor etiologies. But as over time we've found so many genetic factors that are probably playing with those environmental factors, and they're driving that risk from the development of acute all the way up to chronic pancreatitis. And this has been nicely sort of conceptualized in this paper review that was done by David Whitcomb some years ago and published in Gastroenterology, where he showed the different pathways to chronic pancreatitis and described this two-hit phenomenon that was required to develop fibrosis and eventually chronic pancreatitis. I won't spend too much time on this. And this also then factors into some of the proposed pathologic mechanisms of chronic pancreatitis. We've all studied these kind of individually, but the truth is more than one of these may be at play in developing chronic pancreatitis in the individual patient. As you can see with the example of alcoholic chronic pancreatitis. So we know that ethanol is a toxic metabolite to the Astner cell that can lead to oxidative stress and autodigestion. But then we also know that there's an immune activation component that leads to cytokine and inflammatory mediators coming into the intracellular environment, causing stellate cell activation and the development of pancreatic fibrosis. So turning our attention a little bit to acute pancreatitis, let's remember that episodes of acute pancreatitis over time can lead to the development of fibrosis. And this kind of plays out clinically as well. While we know that few patients with acute pancreatitis develop chronic pancreatitis, now about 20 to 30% of acute pancreatitis patients develop acute recurrent pancreatitis, and about 7 to 10% of these patients go on to develop chronic pancreatitis. So thought of a different way, if acute pancreatitis was a cucumber and chronic pancreatitis was a pickle, then pickling sauce is really defined or represented here by the recurrent acute pancreatitis. So I think it's a real simple way of thinking of it. But remember, out of all the people who get acute pancreatitis, very few get chronic pancreatitis. But the Mayo Clinic group just recently published this study where they started with patients with chronic pancreatitis, and then they asked the question, how many of them actually have a prior history of acute pancreatitis? And they found that they reported that this was 50%. But the problem is here is what was their definition of chronic pancreatitis? And that's what I have here on the right-hand side. And I think many of these features are potentially problematic. So here they used endoscopic ultrasound to define chronic pancreatitis, and actually 33% of their patients, and another 8.2% of their patients had simply a compatible medical history. So you could argue that almost half of the patients in this study, I would question maybe whether or not they even really had chronic pancreatitis. When I myself actually went back and looked at my chronic pancreatitis cohort and defined chronic pancreatitis only by the presence of calcifications and moderate to marked changes of the pancreatic duct, we found that 85% of patients actually had a prior history of acute or acute recurrent pancreatitis. So I think it's important, and we're going to probably start to see more and more data on that as we move forward. And this is another important point that I would want to make, is that all the diagnostic tests that we do in chronic or towards diagnosing chronic pancreatitis are focused on early chronic pancreatitis. So I want you to look at the middle panel here of this graph, and these are those patients with early chronic pancreatitis. And as you can see, their clinical features are what we just kind of defined. We were just talking about acute recurrent pancreatitis, right? We talked a little bit about that. We didn't put in risk factors here, but I think that those clinical features probably should really define the risk pool for people who have early chronic pancreatitis, and maybe is really the better diagnostic criteria than some of the diagnostic tests. Here are some of the imaging tests that we use to diagnose chronic pancreatitis, everything from plain films all the way up to CT scans, endoscopic ultrasound, and MRCP. For years, we have been using a ductal grading criteria known as the Cambridge classification. This was actually based on consensus criteria that were developed in the early 1980s to sort of grade the changes of the pancreatic duct in relation to a diagnosis of chronic pancreatitis. And this was actually the normal pancreatogram. And the reason I bring this up is this is actually a normal pancreatogram that was part of the original publication that defined the Cambridge classification. But what's interesting is when I show this around, I tell people, well, what do you think this is? Everyone says this is chronic pancreatitis. Very few people actually say this is a normal pancreatogram. And that defines the problem with this classification scale, is that there's so much inter-observer variability, especially in the early stages of the Cambridge classification, because this one over here is defined as mild chronic pancreatitis, where you have a dilated side branches and a mildly dilated pancreatic duct. And this is severe chronic pancreatitis, where you can see markedly dilated side branches and a really dilated main pancreatic duct. There's also EUS criteria that are used for chronic pancreatitis. I think it's important to note that these have never been verified in relation to a gold standard criteria, because there's no gold standard criteria for chronic pancreatitis. We can use EUS to see if there are features that are consistent with chronic pancreatitis, and they include these parenchymal and ductal features. But it's important to remember that these are non-specific for chronic pancreatitis. So in fact, you can see these in patients who are simply who have diabetes, who are obese, or who are of advanced age. A lot of these features are actually seen in those patients as well, minus the calcifications, which I would say are in fact probably the most pathognomonic morphologic feature of chronic pancreatitis, but it's typically seen in the more advanced stages. This is an EUS of a normal pancreas. You can see a probe is sitting in the stomach, and the pancreas can be entirely imaged through the duodenum and the posterior wall of the stomach. And this is, and if you look down at the bottom, you can see that there's the pancreas is defined as a sort of this thin band of salt and pepper tissue that just lies right below the posterior gastric wall. And here you can see the body and a portion of the tail of the pancreas. And these are just some of the changes of chronic pancreatitis by endoscopic ultrasound. You can see here, here you've got a dilated main pancreatic duct, which you could argue wouldn't necessarily need an endoscopic ultrasound to detect. The middle panel is a patient who's got a hyperechoic duct wall, which is thought to represent inflammation in the wall of the duct. And then you have these echogenic strands on the far right, which are probably the least specific or sensitive feature for chronic pancreatitis by endoscopic ultrasound. So if you kind of look at all these tests and kind of put them into one chart and said, how well do they perform? As you can see, they don't do really well for mild or early disease, but they do really well for severe disease, and they certainly all have some caveats. I've included not only the imaging studies here, but also tests of pancreatic function, including the 72-hour fecal fat, as well as the fecal elastase. I always remind people that the 72-hour fecal fat test is commonly used to diagnose exocrine insufficiency, but remember, it's a test to diagnose whether a patient has steatorrhea. Steatorrhea doesn't mean a patient has exocrine insufficiency. So you can have really bad Crohn's disease and have steatorrhea, and you'll diagnose that by the 72-hour fecal fat test, but that doesn't mean they have exocrine insufficiency. The secretin test, I know that this is sort of more widely gained popularity in recent years. This is this study where we use an upper endoscope. In the old days, they used to use a dryling tube to intubate the duodenum, administer secretin, and then collect pancreatic fluid and assess it for bicarbonate concentration, as well as CCK, although now we're using largely the secretin-based test where we're only assessing for bicarbonate concentrations. But I think it's important to remember that the bicarbonate normal reference bicarbonate concentration is not well known for the population at large. Most of the studies have evaluated patients with a high pretest probability of disease. So we haven't just tested thousands of patients to figure out, in fact, what a normal secretin level is. Also remember that 1 out of 25 Americans carries a CFTR variant, and they may not respond to secretin quite the same way, and their bicarbonate concentration may naturally be depressed. So if you apply this again to a larger population of patients, you may find lots of abnormalities, but no real clear framework for diagnosing a disease like chronic pancreatitis on the basis of one of these tests. Also important to remember that steatorrhea doesn't develop until you've lost about 90% of your acinar cell mass. That's the point at which you begin to see steatorrhea. So of course, there's a lot of debate in the chronic pancreatitis community as to how much lipase do you need to excrete in order to diagnose exocrine insufficiency. Is it a more or less a binary variable, or is it something that lies in the spectrum? And that's not clear. If you go by this study, which was now published almost 46 years ago, nothing's actually disproved this to this date. We still see that patients who have steatorrhea have really lost the highest quantity of pancreatic acinar cell mass. Just some of the mechanisms surrounding steatorrhea. I won't go too much into this. On Sudan stain, you can often see fat droplets when you actually do a qualitative fecal fat study. And these are some of the exocrine function tests that we can do. I think we talked a little bit about the secretin stimulated test. That's really the duodenal studies. And of course, there's some stool-based tests that are also not so accurate. We know that the fecal elastase, in fact, has a false positive rate as high as 40%. And that's partly because there are a lot of patients in the population who have irritable bowel, right? And irritable bowel with diarrhea predominance. So if you test them and test their stool, and especially if it's a watery stool specimen, you're going to get a false positive result on the fecal elastase. So you got to be really careful about interpreting these tests across our population. I think Melina is going to talk a bit about type 3C diabetes. I won't spend time on that. Just a quick regarding complications of chronic pancreatitis. The pancreatic cancer risk in chronic pancreatitis is about 4% over 20 years. Remember, the lifetime risk of pancreatic cancer in the general population is just a little under 1%. But this study from Al Lowenfels has really withstood the test of time. The risk of pancreatic cancer does go up markedly in hereditary pancreatitis. In earlier studies, it was reported to be anywhere from 19 to 54% by the 7th decade of life. So the hereditary pancreatitis is mainly those patients who carry the PRSS1 gene mutation. But in the most recent study by David Whitcomb's group here at the University of Pittsburgh, they found that the risk of pancreatic cancer by the 7th decade of life in hereditary pancreatitis patients was only 7.2%. So markedly lower than the earlier cohort studies. And one of the reasons for that might be is that the earlier cohort studies, a lot of the patients were actually smokers. So that might have actually really pushed up the risk of pancreatic cancer in those patients compared to the more recent US cohort study. So just in conclusion, these are my key points. Chronic pancreatitis is a syndrome, but diagnosis is typically based on advanced morphologic findings. I think we all know that. Complications of chronic pancreatitis occur at variable rates over time, and this is what makes diagnosing this condition difficult as well. But I think really the key point to take away from this lecture is that the risk factors and the presence of acute and recurrent acute pancreatitis, I think, best define really early chronic pancreatitis compared to imaging and endoscopic diagnostic tests. Thank you very much for your time and attention.